Lucy from UTH, and our main presenter, Dr. Kamfwa from the Ministry of Health, our cervical cancer coordinator, and he's also a gynae-oncologist. Kindly use the link in the chat box to register your attendance. We're also joined in with other experts. We have Dr. Funda, Dr. Munalula, Dr. Kaonga, and Professor Faham that are going to be inputting in this presentation and also in the cases that we'll have at the end. I'll now hand over to Dr. Kamfwa to give us the first part of the presentation.
Thank you so much, Dr. Mwenya. And good afternoon, all of you who have joined us on the call. If you look at cervical cancer, it's a public health threat to women, and yet it is considered as one of the preventable diseases, and it is even curable if it has been diagnosed quite early. And we appreciate you out there because of the interventions that you have been doing, particularly in Eastern Province and Lusaka Province. It doesn't. So we appreciate what you are doing in the provinces out there, especially that we are saying that cervical cancer is a public health threat. And if you look at this type of cancer, it is one which is preventable, at the same time curable, especially if we recognize it early. And this is the part where you are involved, especially regarding to secondary prevention, where you are doing the screening. So the objectives for the didactic which we are presenting today, essentially it hinges on epidemiology. And what we want is at the end of this session, we want you to describe the incidence and prevalence of cervical cancer in different regions of the world. At the same time, we would like you to identify the risk factors of HPV infection. Also, you should be able to explain the process by which HPV causes cervical precancer and cancer. And finally, to describe the symptoms of cervical cancer.
So our first question, what is the incidence of cervical cancer in Zambia? Is it A, 44.5 per 10,000, B, 44.5 per 100,000, C, 66.5 per 10,000, or D, 66.4 per 100,000? What is the incidence of cervical cancer in Zambia? Is it A, 44.5 per 10,000, B, 44.5 per 100,000, C, 66.5 per 10,000, or is it D, 66.4 per 100,000?
I think the poll that has been launched is different from what you're reading.
Sorry about that. Sorry about that. What is the incidence of cervical cancer in Zambia? Is it 44.5 per 10,000, 44.5 per 100,000, 66.5 per 10,000, or 66.4 per 100,000? So out of 32 participants, we only have 4 that have voted. Okay, slowly increasing. What is the incidence of cervical cancer in Zambia? I'll allow another 10 seconds. Okay, so none of us think A, the majority of us think B, a few think C, and about 20% think D. I'll end the poll. And this is how we voted. So 70% of us think B is the answer. Okay, let's see what Dr. Kamfwa has for us as we go on.
Okay, so the second question is, all of the following are risk factors for cervical cancer except A, multiple sexual partners, B, high parity, C, smoking, D, bacterial vaginosis. Okay, so question 2 has been launched. Okay, so we just allow just a few minutes, under a minute maybe. Okay, so I think we can end the call. So the majority suggested D. Okay, so let's see what Dr. Kamfwa has to say.
So we move to the third question. Human papilloma virus, HPV, A is a DNA virus, B is an RNA virus, C infects columnar epithelium only, D type 16 is low oncogenic. Which of these is true about HPV? Which of these is true about HPV? Is it a DNA virus, an RNA virus? Does it only infect columnar epithelium? Or is it type 16 low oncogenic? Which of these is true about HPV? So we only have 6 of our participants that have voted. Kindly vote so that we get some feedback on what to concentrate on during the presentation. Okay, we have about 44% that think A is correct, about 21% that think B, 11% C, and about 20% D. I'll allow a few more seconds. What is true about HPV? Is it a DNA virus, an RNA virus? Does it infect columnar epithelium, or is it type 16 low oncogenic? Okay, so we have about 57% participation. I think I'll end the poll now and we can have a look at how we voted. So 45% think it's a DNA virus, 23% an RNA, 14% think it infects columnar epithelium only, and 18% think type 16 low oncogenic. So move to the fourth question.
So the fourth question says, what are the 2 most prevalent types of HPV that causes 70% of cervical cancer worldwide? A, 6 and 11, B, 11 and 16, C, 16 and 18, D, 6 and 18. Okay, so we've launched the poll. So you can start answering. Okay, so we require your full participation. Kindly participate. Okay, so we're ending the poll now, okay? Okay, and the fifth question says, what percentage of CIN1 is likely to progress to invasion? Okay, A, 1%, B, 10%, C, 20%, D, 30%. Okay, so we're just launching now. Okay, so we're ending the poll. So thank you so much. Okay, so seems the majority.
So we have about 32% that think 10%, 32% as well that think 20%, 21% that think only 1%, and 16% that think about 30% of CIN1 cases progress to invasion. So we can listen to Dr. Kamfwa's presentation.
Thank you so much for the overwhelming response and the diverse in terms of the answers that you have given. If you look at that world map, what it is showing us is that the countries where there is the highest HIV prevalence are the same countries where we find the highest incidence of cervical cancer. So when we are talking about incidence of cervical cancer, we are talking about the number of new cases per given period. It is quite different from the prevalence. When we are talking about the prevalence, we are talking about the existing number of cervical cancer cases. Now look at that world map, especially with the color code. You are going to find that where it is deeper, that's where we even have the highest HIV prevalence. Coincidentally, that's where we have the highest incidence of cervical cancer. Now, when we are looking at the incidence, where do we stand as a country? Zambia, we are the third highest age standardized incidence rate, be in sub-Saharan Africa or globally. Now, if we are the third, who do you think could be the first and second? The first is Eswatini, and the second is Malawi. Then we, Zambia, we are the third. Of course, we should not be happy that we are the third because this is a disease which is purely preventable. And when we look at this disease, it is the commonest cancer, accounting for 22.9% of new adult cancer cases. And where do we get this? So annually, including, the patients that, or the clients that you have been seeing, we see 3,000 plus new cases in Zambia. And out of that, close to 2,000, which is 1,900, they die. So meaning that if we talk about the incidence, we calculate the incidence out of 100,000 women. The incidence is calculated out of 100,000 women. So where do we stand as Zambia, despite saying that there are at least 3,000 new cases and 1,900 deaths? So in terms of the incidence for Zambia, it is around 66.4 per 100,000 women. And out of that, it is 44.5 per 100,000 mortality. So if you see, we have got one of the highest in terms of mortality and even in terms of the incidence. And when you look at that map, what we are seeing is that 80% of the cancers in terms of the incidence and the deaths, they occur again in women who live in middle income countries such as Zambia. No wonder you are key partners in as far as trying to mitigate this is concerned. You have been doing the screening. That's why we are trying to reach out to you, especially that we want to reduce this incidence to 4 per 100,000 women, according to WHO strategic plan, which has to go to 2030. So the strategy for WHO, for us to say this disease can be eliminated, it's when the incidence comes to 4 per 100,000 women. Look at where we are, 66.4 per 100,000 women. So when you look at cervical cancer, indeed, it is a big burden. And if we look at it on the global scene, it comes as fourth. Which one is first? First is breast cancer, followed by lung, colorectal, then cervical cancer comes as fourth. And when you look at this disease, at the beginning, we said that it is a preventable disease. And in Zambia, it peaks at around 35 to 49 years of age. But look critically at that 35 to 49 years of age. That is the peak for the caregiver. That is also the peak for people who work, meaning that when there is a group who have suffered from cervical cancer, it means it has got an effect on socio-economic indication. And when you look at this cervical cancer, just get back to your facilities. Most of the patients that you screen, we say those who are living with HIV/AIDS. Why is it like that? The concentration is on those who are living with HIV/AIDS. Reason being is that those have got 5 times higher in developing cervical cancer as compared to those who are HIV negative. But why should it be like that? It's because those who are HIV positive, one, they have got persistence of HPV infection. Second, they have got high prevalence of HPV infection. Third, even when they have got pre-cancer, to transition to cancer, it only takes a very short period. So that's the more reason why we concentrate even screening these who are HIV positive, but we do not have to forget those who are HIV negative. So one thing that you need to realize is that HPV causes nearly all cervical cancer. 99% of cervical cancer is caused by HPV, meaning that we need to understand what is this HPV, the so-called human papilloma virus. Sooner than later, the primary screening test, which we are going to adopt. I know, Lusaka, you have been very, very happy. You have even started doing HPV DNA testing. This is what we are going to adopt as a country. So it is important for you to understand or to have information on HPV, because it is what causes this cancer. So human papilloma virus, it is a DNA virus. And for sure, there are more than 100 subtypes which have been identified. But for the clinical purposes, what we normally do is to classify these as either low risk or high risk. Examples of low risk, it is 6 and 11, type 6 and 11. Type 6 and 11 is the one which has been associated with genital warts and some subclinical HPV infection. So when you see condyloma mat, the warts, not necessarily vulval cancer, but vulval warts. One thing that you need to appreciate is that it could be that the subtype of HPV that has caused that is type 6 and 11, because these two, 6, 11, they are low oncogenic. But again, we said that there are those which we call high risk subtypes. Examples of high risk subtypes. We have got type 31.
Let's kindly mute our mics as we log in. Kindly mute your mics. Thank you.
So please, we were trying to talk about the subtypes. We said that for clinical purposes, we classify HPV as either high risk, which are the oncogenic subtypes, or the low risk. And we have isolated two low risk, which is type 6 and type 11. So type 6 and 11, they are the ones that cause most of the warts that you see. Then we have got the high risk, 16, 18, 31, 33, 35, etc. These are the ones that cause most cancers, and they are 14 in total. So, if you look at HPV, it is one of the most common sexually transmitted infection. In fact, 75% of both sexually active men and women at some point in their lifetime, they will pick up this virus. But the most important thing is it depends on the immune system of that person. If the immune system is very, very good, within 1 year, 6 months to 2 years, that HPV won't be there. But if the immune system is not good, you are going to find that there is going to be persistent of that HPV. But let's again look at the high risk or oncogenic type of HPV. If we look at subtype 16 and 18, just these two, 16 and 18, they are the ones that account for 70% of cervical cancer. And just those two, again, when we isolate, 16 itself accounts for 50%. But the most important thing for you is to look at 16 and 18. These, they cause 70% of cervical cancer. But one thing again that you need to know is that HPV does not just cause cervical cancer. So if a woman is going to come who has got vulval cancer, not vulval warts. Vulval warts, it will be 6 and 11. But vulval cancer, it is going to be high oncogenic HPV 16, 18. Vaginal, as long as that vulval cancer is in the younger population, not in the older population. In the older population, it is not necessarily going to be HPV. It is going to be because of lichen sclerosis, not necessarily HPV. But when you talk again of vaginal cancer, it is also attributed to HPV. When you talk of anal cancer, it is also attributed to HPV. When you talk of throat cancer, it is also attributed to HPV. So HPV doesn't just cause cervical cancer, but for you, it is one of the most important things. And remember, like what I said, as a country, the primary screening test is going to be HPV. No wonder we want you to be equipped with this knowledge. So when we look at cervical cancer, while we have said that HPV is necessary, it is not sufficient. I'm saying HPV is necessary to cause cervical cancer, but it is not sufficient, meaning that we are supposed to have some core factors. So what are those core factors or the risk factors? The first, like even what we said at the outset, is immunosuppression. Those who are HIV positive. Why? Because remember, what happens with HIV and cellular immunity? Second, smoking. Smoking is one of the factors that is also associated with cervical cancer. unhealthy diet. Fourth, long-term oral contraceptive use. Please, let's try to look at long-term oral contraceptive use. When you are in the facility, we have used the word long-term, and again, we have used oral contraceptive pill. What do we mean by long-term? This is where somebody has been using oral contraceptive pill for more than 5 years. When there is use of that for more than 5 years, there is a doubling effect in as far as the risk is concerned. But when a woman stops using that, that risk eventually goes down sharply, and within 10 years, she is free. So meaning that what we need to concentrate is the benefit versus the risk of using oral contraceptive pills. By and large, there are more benefits of using oral contraceptive pills than the risk of having cervical cancer. So even when you are there, please do not start talking of oral contraceptive pill as the most important risk factor, unless this has just been brought to your attention. But again, know how to explain that so that you do not start scaring people and they start shunning from getting the benefits of oral contraceptive pills, please. Then there is multiple full-term pregnancies, above 4. Those women who have given more than 4 full-term pregnancies, there is that risk. Of course, we know about multiple sexual partners, and again, where there is early sexual intercourse, especially below 16 years, combined with early age of first pregnancy. Why should this be a risk factor? When you look at those who are below 16 years, we can say they have got an immature cervix. And basically, there is an element of ectopy. And this is the one which is susceptible to HPV, and because of the microabrasion, and it can stay longer. The same thing applies to early age of first pregnancy. So these are some of the risk factors. So you need again to understand, how does this HPV then cause cervical cancer? One thing that you should realize is that this HPV likes going to the epithelium, and when it goes into the epithelium, what will be happening is that it is going to be integrated, or in other words, to incorporated into the cells of the human being. So we have got this HPV, which is a DNA. It has gone to the epithelium of the cervix, and then it goes into the DNA of the human being. So what it is going to do during that time, it will start producing what we call oncogenes, E6 and E7. These are oncoproteins. These two are what will then interfere with what we call tumor suppressor genes. We have got P53 and RB gene. These are the genes that tell the body saying, please do not just continue multiplying. There comes a time when you multiply and you die. But in a situation where these tumor suppressor genes have been interfered with, the cell will continue just multiplying, proliferating like that. And this is what is going to lead to cancer as the end point. So the thing that we talked about is, look at what is happening. So there is that infection with HPV. Look at the red dots. So those red dots, what they are going to do is they will go deeper down and infect the cells that are at the bottom, sitting next just to the basement membrane. And there is going to be that replication of the virus. After replication, in these women, especially those who are HIV positive, it may not even take 10 to 15 years. It may even take shorter period of time. All of a sudden, what will be happening is that the basement membrane, it is going to be damaged, and that's the time that we are going to say this person has got now cervical cancer. So briefly, this is what happens. So when you look at the diagram, what we are trying to depict for you, look at the pictures. The first is a normal cervix. The same ones that, the same pictures that you normally get when you are in the screening rooms. So that is going to be infected with the virus, and it depends on the immune status of that person. So that person is going probably to clear the virus. And remember what we talked about, if somebody is immune competent, within 1 year to 2 years, they are likely to clear the virus. If they haven't cleared, look at the next picture. What is going to happen is that that is going to progress. When it progresses, we start then having precancerous lesion. And the precancerous lesion, these are the lesions that you see in the clinic when you have put vinegar on the cervix and they start turning into white. We have that acetowhite lesion. Sometimes there is a regression, but if regression hasn't occurred, that is going to lead to invasion, and that's the last thing. And of course, this is going to depend on the correlates or the cofactors. Now, despite such a thing, there is what we call a continuum of care in as far as the control of cervical cancer is concerned. And what normally happens is that it has been divided into primary prevention. So look at the different color codes on that. We have got the red, which is trying to talk about the primary prevention. Then we have got the blue, which is talking about the secondary prevention. And we have got the green talking about the tertiary prevention. When we focus on the primary prevention, this is where we do not want a woman or a girl to get HPV. So what are some of the things that can be done for somebody not to get HPV? One is sexual education. 2, use of condoms. 3, circumcision. But the most important thing is HPV vaccination. And you know, as a country, we have been vaccinating all those who are below 15 years. We do give 2 doses. And that has helped a lot. But in the future, we are going to see that for sure, this vaccination that we have done, coupled with the screening, is going to substantially reduce the number of cases. And when you look at that time that we want the vaccination to be done, it's when our girls have not yet been exposed to HPV. One thing that you need to realize is that between 20 to 25 years, that's when we have the highest prevalence of HPV. The highest prevalence of HPV. When do we normally see the pre-cancer? They are normally seen between 25 to 45 years. They are 25 to 45 going to 59, somewhere there. And this is the time that we do secondary prevention. If you look at our guidelines, even for HPV, we shall be screening the women between 25 years to 59 years old. That is secondary prevention. In secondary prevention, this is where we do not want that pre-cancer to turn into cancer, and we have to treat. So when you are doing VIA as a screening method, this falls under secondary prevention. So when you start doing when you start using HPV, DNA or RNA, it is secondary prevention. How about tertiary prevention? So tertiary prevention, this is where somebody has got cancer. Sometimes what happens is that you diagnose saying, oh, let's do the biopsy on this cervix. And you find that when you are saying it's query ICC and it comes as invasive cancer, what do? You send these patients to the gynecologist. So there are 3 ways that we can do tertiary prevention. If it is in the early stage, like what I said, early stage cervical cancer, we treat with surgery. Early stage, we can treat with surgery. Where surgery, when it has gone beyond where we were supposed to treat with surgery, this is the time now where we come to use chemotherapy and radiotherapy. All that is incorporated into the tertiary prevention. Now, there are these terms that we want, there are these terminologies that we wanted you to know, because half the time you, the providers, you'll be talking about this patient has got CIN1. So first of all, the acronym CIN stands for cervical intraepithelial neoplasia. And what has happened is that these are divided into CIN1, CIN2, and CIN3. When you look at CIN, we call it a low grade. It is low grade. In fact, it is not a pre-cancer per se. It is essentially because of the infection with HPV. But it is a low-grade squamous intraepithelial lesion. And this is what is even gotten when people have done cytology. But when you talk of CIN2 and CIN3, these are high grade. And I'll elaborate why we require to treat CIN2 and CIN3. So look at that diagram, what is happening. If you look at CIN1, what is this thing that we say, this is CIN1? So first, like what we said at the outset, when HPV enters into the cervix, it is going to go to the bottom cells. So those bottom cells are going to be infected. So if it is 1/3 of the layer of the cervical epithelium from the bottom, which has been infected, where there is disorganization of the cell, we call it CIN1. So from the bottom to 1/3, CIN1. If it is from the bottom up to 2/3 of that, we call it CIN2. If the entire epithelium has been involved, then we call it CIN3. But there is a term that should be brought into your attention: carcinoma in situ, CIS. Just because you hear of the word carcinoma, it doesn't mean the patient has got cancer. Because what has been happening sometimes from the provinces, we receive referrals to CDH. They say this patient has been referred because she has got carcinoma in situ. Carcinoma in situ, in fact, that terminologies, we are trying to do away with it. Carcinoma in situ is synonymous with CIN3. But look at the end. When the basement membrane has been damaged, then that's when we say cancer has happened. So CIN1, CIN2, and CIN3, these are not cancers. These are pre-cancers. And it takes about 10 to 15 years. Please, 10 to 15 years, it's those who are immune competent. Those who have HIV, they do not have the luxury for 10 to 15 years. The period is shorter. Sometimes it can just go between 5 to 10 years. So the terms that are important for you to understand is regression, persistence, and progression. Let's look at CIN1. CIN1, for it to go to cancer, to say this patient has got CIN1, now is going to develop cancer, it is less than 1%. CIN1 to go into invasion, it's less than 1%. What does it mean, especially for LEAP providers in the provinces? So you lip providers in the provinces, when you have done a lip and it has come out as CIN1, whether they have said that the margins are involved or the margins are free, one thing that you need to realize is that do not tell the patient that we have to repeat lip because the margins are involved. Bear in mind that for that to go to cancer, it is less than 1%. Much of it, 60%, is going to regress to normal. So this is the knowledge that we want to equip you, the nurses, you who are the providers. Sometimes you'll be going to the doctor saying, well, this patient, they did a lip and it came out as CIN1. Remember, I was trying to explain what CIN1 is and what will happen to it. It is a low grade. It is a low grade. So even when a pap smear comes, low grade squamous intraepithelial lesion, just know it's CIN1. However, when we talk about CIN2 and CIN3, if we combine these two, you know what? They'll go to about 25 to 30%. So these are high grade. So with these, immediately you have done the lip in the provinces and we find that the margins are involved. That patient requires a relief. Why? Because 25 to 30%, there is a likelihood that that is going to go into cancer. But if the margins are free, we see the patient after 12 months. So this is the thing that we want to look at. CIN1, less than 1%, and like that. So what we were trying to talk about, the development of cervical cancer, is depicted in that. And that's the same thing that it is showing. So how about when we want to talk of the symptoms of cervical cancer? There are some women who are essentially going to come as asymptomatic. They'll come to the cervical cancer screening room. They are asymptomatic, and yet they have got cervical cancer. And those are the women who have got early cervical cancer. By and large, there are those women who are going to present to you with symptoms. The symptoms might be pain in the pelvis, or in the legs, or in the abdomen, or at the back. Remember, when they are presenting with this, already it is in an advanced state. We know why they are having pain at the back. It could be that now the nerves have even been involved. Again, they may present with abnormal vaginal bleeding, or abnormal menstruation, or heavy menstruation, or irregular menstruation. So in the districts or in your facilities, when there is a woman within the reproductive age group, not just within the reproductive age group, even the postmenopausal. First, let me start within the reproductive age group. If they have got abnormal menstrual period, please do not say this is because of hormonal imbalance. No, what you do is ask that woman to come to cervical cancer screening clinic, so that you put the speculum there, you look at the cervix, and you put vinegar. It could be that you are missing an opportunity in a woman who have got cervical cancer. And these are the women sometimes who tell us, saying, I've been going for screening, but I don't know, after maybe 2 or 3, I've got now this cervical cancer. Postcoital bleeding, again, do not say, well, this woman is bleeding because of other things. It could be that. That is a telltale sign that there is cervical cancer. Postmenopausal bleeding, we don't want to see a woman who had stopped going for pills, then she starts bleeding. The last, abnormal vaginal discharge. We know every woman has got a normal vaginal discharge. But when there is this discharge which starts becoming watery, foul smelling, we shall know that saying, this is a big problem. I thank you so much for listening to that.
Thank you very much, Dr. Kamfwa, for that elaborate and very informative presentation. So we'll allow a few more questions. We'll allow some questions, then we'll relaunch the pause. Then we'll have two cases. We have two cases, one coming from Chipata and Kanyama. So in the interest of time, we'll launch the poll questions. We'll allow two questions, then we'll go to the cases.
When do we launch?
Sorry about that.
Yes, those three dots. Okay. At the right at the bottom. Next.
So we said that when we are looking at incidence, which is a rate, for cervical cancer, we calculate it out of 100,000. So anything which is 10,000 is wrong. So we calculate it out of 100,000. And we said that we are standing at 66.4 per 100,000. When there is that other figure, 44.5 per 100,000, it is mortality. So we were talking about the incidence, and this is D.
Thank you.
Yeah, so thank you so much. So the second question is, all of the following risk factors for cervical cancer except A, multiple sexual partners, B, high parity, C, smoking, D, bacterial vaginosis. Okay, so let me read out the question again. So all of the following are risk factors for cervical cancer except A, multiple sexual partners, B, high parity, C, smoking, D, bacterial vaginosis.
Thank you so much for the overwhelming response. Of course, the except answer is D, which is bacterial vaginosis. when you look at high parity, and we talked about those who have given 4 and above full-term pregnancies, they are at risk of cervical cancer.
Okay, so we're moving on to point number 3. Okay, so human papilloma virus, HPV.
Is it A, a DNA virus? Is it B, an RNA virus? Is it C, that it only infects columnar epithelium? Or D, is it type 16 low oncogenic? What is true about HPV from those options? Is it a DNA virus, an RNA virus? Does it only infect columnar epithelium, or it's type 16 low, is type 16 low oncogenic?
Thank you so much again for those responses. We said that human papilloma virus is a double-stranded DNA virus. It's a DNA virus. I know probably what could have confused you is we shall be, in the testing, we shall be using DNA as well as RNA, but the virus itself is a DNA virus, which is double-stranded.
So moving on to question number 4. Okay, so what are the 2 most important types of HPV that causes 70% of cervical cancer worldwide? Is it A, 6 and 11, B, 11 and 16, C, 16 and 18, D, 6 and 18?
Thank you so much for that response. Remember when I said 6 and 11, when you just hear 6, it's low risk. 6, low risk. 11, low risk. The 2, which cause 70% of cervical cancer worldwide, it's 16 and 18. 16 and 18. So that answer on top, which is 6, 11, it is just going to, it won't cause cancer. It will just be subclinical infections such as warts. So the answer is the same, which has been given as C, 16 and 18.
Okay, so question number 5. What percentage of CIN1 is likely to progress to invasion? So A, 1%, B, 10%, C, 20%, D, 30%.
Thank you so much again. We said that the chances of CIN1 to go into invasive cancer is less than 1%. It's less than 1%.
Thank you very much for your participation. Thank you very much, Dr. Kamfwa. We'll allow one question before we go into our case presentation. To allow one question. In the interest of time, make your question as brief as possible. We'll allow one question. I'll open it up to the network. We'll allow one question. Okay, we don't have any hands up and there's no question in the chat box. So we'll go straight to our, okay, we have a comment in the chat box. Good afternoon. My question is on the clients who test positive for HPV and test negative for VIA. Is there any preventive measure for that client, or we're going to wait for that HPV to replicate and test positive for VIA? That's when measures are going to take place.
Thank you so much for that question. We are working on the guidelines. Now, let me just maybe tell you on the guidelines the way it is. So for the patient who is HIV positive and the HPV comes out as negative. So she's HIV positive, then the HPV comes out as HPV negative. We are going to be screening that person with, or we are going to be triaging that person. So there's going to be first triage and there will be a second triage. So when this HPV is positive, first of all, what we do is we shall be using, again, vinegar, and this time we shall be calling it VAT, because we want to assess the type of treatment that we shall do to that patient. So HIV positive, and like what you have said, now she is HPV positive. The next step is to do VAT. You put vinegar still on the cervix and you use the camera. There now you assess, is this lesion eligible for ablation, or is this lesion eligible for LEAP? So depending on that, you treat, and we review the patient after 12 months. How about in a situation where this patient is HIV positive but HPV negative? What do we do here? Again, it will depend on the transformation zone. When we do the triage, it is going to depend on the transformation zone when we do the triage. But for the ones who are going to be HPV positive and they come out as HPV negative, we are going to be seeing them after 3 years.
Thank you very much, Dr. Kamfwa. Namonda, who asked the question, I hope that explanation is clear. So in the interest of time, we'll go straight to our cases. Then Fales Chira, who has the hand up, I'll allow you to ask your question towards the end. Kindly keep that question. Then we hope we'll be able to answer it towards the end. So we'll now hand over to Tim Kanyama to take us through this case. Mr. Fred Nguni, are you on the call?
Yes, please, I'm on the call.
Okay, thank you. You can go ahead and present the case from Kanyama.
Thank you very much. So my name is Fred Nguni from PHO. So I'm going to present you this case from Kanyama. So this is a case of the 30-year-old female on ART since 2013. So this image you are seeing is a picture also which was taken in 2014 when doing VIA, and the diagnosis was VIA positive, and thermoablation was done on the picture in 2014. So this woman was given 1 year as per guideline after a positive lesion treatment. So the woman came back in 2015 and VIA was negative, and the patient, the woman was given 3 years review as per review guideline. Then this woman never showed up. Only came back in 2019 with a draining, supposed to come back in 2018, the 3 years from 2015, but only came back in 2019 with draining, as you can see on the image. And the provider at that time could not come up with a proper diagnosis. As you can see, there's contact bleeding there. And this woman was given antibiotics and asked to come back 2 weeks after the antibiotics. So the client never showed up, only to be seen recently in 2021 when she came for drug pickup at Kanyama. Then she was referred to for, okay, next slide. Next slide. Oh, okay. So what I'm saying is this woman only showed up in 2021, this year, for drug pickup at Kanyama, and she was referred to cervical cancer. Then she produced a card from CDH that she's on a cancer treatment. She was diagnosed with cervical cancer stage 3B. So now the question would be, looking at what transpired to this woman, what strategy can be put in place to prevent such cases of this woman? Because we believe that this cancer could have been prevented. So maybe we need help from the core. I submit for this case.
Thank you very much, Mr. Fred. So just to summarize, we have a female 40 on ART for 8 years, history of VIA positive in 2014, thermoablation was done. So she went for her 1-year review, then she was told to go back 3 years later, but she didn't go for her review. And then she later presented with cervical cancer stage 3B and was referred to CDH. So the question is, what strategy can we put in place to prevent such cases? What strategy can we put in place to prevent such cases? So before our experts come in, we'll allow the network to give their opinions. Before our 4 experts come in, we'll open it up to the network before Dr. Fundafunda and the other experts come in. What do we think should be put in place to prevent such from happening to other women that present in a similar manner?
Good afternoon.
Thank you. Kindly introduce yourself and the facility you're coming from.
My name is Besna Tingandu. I'm based at Matero Level 1 Hospital, working under UNC Global Projects. Concerning the case that was just presented, I think those women whom we cannot clearly see the transformation zone and they are above the age of 45, it's ideal to advise them to do the pap smear test instead of the VIA examination. Thank you.
Much. We have an answer from Matero. Do we have anyone from Chilenge that could give a go at the question? Anyone from Chilenge sub-district? Sister Erica, Sister Zelipa, Sister Cecilia, what would you have done if you're the one attending to this patient? A hand from Grace Perry. Grace Perry, you can go ahead and give your contribution.
Hello, good afternoon, everyone. Like in my opinion, I think the best way to go is, as the earlier speaker mentioned, that the transformation zone really goes in as we age. I think it's better to do an HPV test as well before, just to rule out any infection. I think it can really help us because we can't really see the transformation zone since it's inside. So it's difficult to really do a correct test when you're just doing VIA. My opinion, thank you.
Much in under 1 minute, Gize, you can go ahead and give your contribution in under 1 minute.
Okay, on the first picture, yes, the VIA was positive. Even the second picture, the VIA was positive, but there was a misdiagnosis. So there was need for QI of the pictures so that they would have called back the client to come back because the transformation zone was able to be seen, though it was type 2 at that time. So the lesion was seen just on top a bit in the second picture. Thank you.
Much. So we'll ask one of our experts, Dr. Fundafunda,
Good afternoon.
Good afternoon.
Yeah, so this is a patient that we saw initially and gave thermoablation. So when she came back, 2015, that was a year after, in 2015, then she was given 3 years to be reviewed. Being HIV positive means that even her progression is going to be of a shorter period. If she, in these 3 years that she was given to be seen, to be reviewed, where she moves from CIN1 to CIN3 or into invasive cancer, it takes to take a shorter progression period than somebody who is HIV negative. Then in a patient where we can't see the transformation zone, I think it's ideal to do an endocervical curator to get since the transformation zone has moved, so that we can get the biopsy of the endocervical canal. Then we can safely say give this patient maybe 1 year or 2 years review, because 3 years could be a longer period for someone whose transformation zone is not visible. Then the other thing, I don't know whether how feasible it is, whether we could get these plans, whether we could have a database that could give a prompt to the caregiver to call these patients who don't turn up on the time that they're given to come for reviews. Yeah.
Thank you very much, Dr. Funda. So we need to be more proactive when we have such cases and try and follow up these women in the shortest time possible, knowing that because they're HIV positive, the progression is faster. So we have a few comments in the chat box before we go to the next case. Professor Paham, are you on the call?
Yes, ma'am, I am. Can you hear me?
Yes, we can hear you. Thank you.
Thank you. So this is a very, very interesting case, and it is something that is troubling, and we are unfortunately beginning to see more and more of these cases. Not a lot, but it doesn't take a lot to alarm you, to alarm one, because you know it's when these women initially come, they have something that is curable. And then when they come back, it's something that has a low cure rate, like a big invasive cancer.
Professor, are we still together? Professor Paham?
Wonderful. I think Besnard and Gizi and Dr. Funda. So VIA as a screening test only works when the transformation zone is fully visible, and particularly the squamocolumnar junction. That junction where the columnar epithelium meets with the squamous epithelium, because that is the part of the transformation zone where if there is a lesion, that's where the worst lesion is going to be. But overall, VIA as a screening test only works in a type 1 or type 2 transformation zone where you can see all of the transformation zone and thus the lesion. Because when a lesion develops, it is going to be in the transformation zone. They don't usually occur outside the transformation zone. So it works if the lesion is fully visible and the transformation zone is fully visible. If that squamocolumnar junction goes inside the canal, VIA cannot tell you what's in the canal. It cannot peep inside the canal. Your eyes can't see longitudinally, so you don't know what's in there. The outer part of the cervix, the ectocervix, and there may be a part of the squamocolumnar junction that you see, But if you can't see all of it, even if a part of it is inside, that's a type 3 transformation zone, and the VIA test fails. And as Besnard said, that's when you have to say the VIA test doesn't work. So essentially, this woman has not been screened. So then you have to find another way to assess what's up in the endocervical canal. And we have 3 options: the pap smear, as Besnard said, the endocervical curettage, where you take this special instrument and you stick it inside the cervix and you scrape those cells 360 degrees, put them on a piece of paper in formalin and send it to the lab. Or the other option is to do a leap to remove the endocervical canal. That's the most aggressive form, but it depends on what you have. If you no sense in doing a pap smear if you don't have anybody who's going to read it. No sense in doing an endocervical curettage if your pathologist doesn't really know how to read those things. And then you have the leap. So you have 3 options, but you have to tell yourself, this woman has not been screened. Now, unfortunately, we used to say, if as long as you don't see a white lesion on then it's VIA negative. That's incorrect. We instructed you incorrectly. So now the new teaching is that if the transformation zone is up inside the canal, then you have to say not VIA positive, not VIA negative, but maybe VIA indeterminate, or VIA has failed. And so she has not been screened. So then you got to turn to something else to investigate what's going on in the canal. And the reason this is important is because of Zambia's success in getting ARVs out to HIV positive patients. And I'm talking about HIV positive now. And so more and more HIV positive women who are really at the highest risk for having cancer are living longer. So they're going to get into the 40s and 50s and postmenopausal, where all of that transformation zone is going to be up in the canal. And then any postmenopausal woman, whether she's HIV positive or negative, that transformation zone is going to be up in the canal. So we have to find another way to evaluate those women other than using VIA, or we're going to be seeing more and more women like this, where we tell them they're negative and they really have a bad pre-cancer, or maybe an early cancer up inside the canal, and then they come in. I think one of the big tip-offs in this case was the bleeding. If she's symptomatic, having pain or bleeding, or a purulent discharge that she can't get rid of, then you really know that there's something up inside. But even if she's asymptomatic, we have to be aggressive in finding another way to evaluate the endocervical canal, or we're failing these women. So that's that. I think this is a very great case for something that we're being confronted with more and more. And I think Dr. Kamfwa and his team are going to address this in the new cervical cancer screening guidelines, which will help the nation to have a consistent way of dealing with the type 3 transformation zone. Thank you.
Thank you so much, Prof. Just in addition, because there was a comment which came from someone where they said, because VIA is negative, then the next you should do HPV. No, in the screen and treat, we are not going to be moving. We are not going to be moving from VIA to HPV. No, what we shall be doing is what Prof. Paham has explained. Where you cannot see the transformation zone, do not start to say, we do HPV. No, do either endocervical curettage or do cytology, or like what he said, the aggressive one, leap, but not to say VIA is negative in this 61-year-old, then we do HPV. No, in the algorithm for screen and treat, in which HPV is in which VIA is the primary screening test. It is not followed up by HPV.
Thank you very much, Dr. Kamfwa and Professor Parham. So we'll quickly move to the second case. Mr. Fred, you can take us through the case from Chipata General.
Thank you very much. So this is another case from Chipata. So this is the case of a 29-year-old on HIV positive on ART since 2017. So she's para 2. She was referred from this woman was referred to Chipata General Hospital for LEAP, as the VIA was done at Chaisa. So we're told, and according to them, it was VIA positive, and they thought it was LEAP ablation ineligible. So they referred to Chipata General Hospital for LEAP. So she presented with complaints of back pain, postcoital bleeding, and foul smelling discharge. Next slide, please. So patient had no medical comorbidities, and the LMP was on the 4th August 2021, and she was also on contraceptive Depo Provera. Next slide. So upon arrival at Chipata General Hospital, the first image was taken, the one on the left, and the provider suspected the query, suspected the cancer, invasive carcinoma was the service, and the punch biopsy was done at Chipata. So the woman was called back on the 18th to come and receive her results, and the results showed a low-grade squamous inferior lesion. And since it was low grade, they decided to do a thermal ablation on the same date. So that's the second picture that you saw on the time she was called. So now our question, so now the question is, was it a proper diagnosis and treatment for considering the two images that we've seen? And what is the follow-up for patients when the biopsy results show a low grade squamous inferior lesion? We decided to review the patient, the same client, after 1 year following the ablation therapy which was done. I submit.
Thank you very much, Mr. Fred. So we have a female 29, para 2 on Depo. She was referred for LEAP on the 11th of June this year. A punch biopsy was done, which showed LCIL, low-grade squamous intraepithelial lesion. And on the 18th of August, thermal ablation was done. So what is the proper diagnosis and treatment for this patient? And what is the follow-up for patients when the biopsy is low-grade or LCIL? So for the first question, what is the proper diagnosis and treatment? We'll allow the participants on the call to give their input. What is the proper diagnosis and treatment for this patient? So she's a female 29, para 2, with complaints of backache, postcoital bleeding, and foul smelling vaginal discharge. Punch biopsy done on 11th June this year, which showed low-grade squamous intraepithelial lesion. On 18th of August, thermal ablation was done. So what is the proper diagnosis and treatment for this patient? Okay, in the interest of time, I'll ask Dr. Munalula. Dr. Munalula, if you're on the call. Dr. Munalula or Dr. Kaonga?
Good afternoon.
Good afternoon, Dr. Kaonga. Thank you. You can give us your contribution.
Yeah. What I'm not getting clear is the abrasion. Was it done after the biopsy or before the biopsy?
Okay, so the ablation was done after the biopsy when this woman came to receive the biopsy report.
Okay, okay. Yeah, but basically we are told, which meant that there was a reason for them to do a biopsy in the first instance. And possibly they suspected the ICC. Only that, do we beam the picture there? Okay, in short, since they had the biopsy which came out as LC, I'm showing the presentation of the moderator, Dr. Kamfwa, indicated clearly the percentages of progression and regression. So in this case of an LC, we need to just give an appointment for follow-up. And then depending on the status, I'm sure we have been given an elaborate information on the HIV positive and HIV negative woman. So the shorter for HIV positive woman given a shorter follow-up duration. So for LC, obviously it should have been treated just as a follow-up. In addition, of course, it is also an advantage to overtreat, since initially the team could have been, who were on the ground, were pretty suspicious. The overtreatment is still acceptable. So if it was only LC follow-up, of course, shorter than the HIV negative woman, but overtreatment is still acceptable. Thank you.
Very much. Dr. Swali, in under 1 minute. In under 1 minute.
Thank you. So I'm not very comfortable with the history and the diagnosis, because the false main discharge could mean that their suspicion of ICC was very, very likely, but the diagnosis of low CO, it tends to me, I tend to think that maybe they got a biopsy on an area of the cervix where there was low CO, because invasive carcinoma may not be all around the cervix. So maybe the biopsy was taken from a position where there was low CO. But the thermoablation for low CO is correct management. Although it does not give us the depth of treatment and whether we got clear margins, unlike a lip, which would give us clear margins and give a comfortable counseling for the patient on this on the condition. Thank you.
So Dr. Fundafunda, when you look at that picture, the one on the right, do you think that's a cancer? You think that's a squamous cancer? You think she has cancer on that cervix?
It doesn't look exactly, but the history that this lady gave, I would make me think maybe just to be, would make me think that I need to have a very close eye on this patient so that we don't miss her. These are the patients that I would want to keep a reminder on myself to ask them to come for a review within a year.
I mean, you can clearly see the squamocolumnar junction. There's no lesion there. The squamous epithelium looks normal. The columnar epithelium looks normal, unless you think she has an adenocarcinoma that's up inside the endocervical canal. But clearly, there's no visible evidence of a squamous cancer here. It looks like ectomy, obviously. Paul, what do you think, Dr. Kamfwa?
So sometimes you are going to be getting these cases which are going to be confusing you. Just because somebody has said they are querying ICC does not necessarily mean for sure what is going to be presented before you is ICC. No wonder you are supposed to do your own evaluation. When you look at the evaluation which was done, it doesn't necessarily review cancer. So when they did the biopsy, of course, it comes to show that what is there is LC. And in LC, like what we said, when they applied this thermal ablation, it was good. They had to overtreat. But if they left her just like that, again, it would have been fine if it is purely LC. Yes, Prof.
Okay, that's fine.
Okay, thank you very much to you all that participated. I hope that we've used the link in the chat box just to register our attendance. So we have a few comments in the chat box where someone is talking about issues to do with the camera, with settings and all those things. So Jane M Galaxy Tab says, if the camera is in the facility, they can indicate where the camera is and it can be reset. Issues to do with the camera. Then someone also states that we can get our cameras from Hayden Medicals or Leica, where they usually give all the accessories without anything missing. So someone did note a challenge to do with camera parts. Do we have any burning question from the network? If we have any burning question, just one question for the professor and the other experts. Okay, so since we don't have any questions, I'd like to thank you all for joining us in this first ever Cervical Cancer ECHO for Lusaka and Eastern Provinces. Thank you to Professor Parham, Dr. Kamfwa, Dr. Fundafunda, Dr. Kaunga, and the rest of the team from University of North Carolina. Thank you for each of you participants that took time to log in for this session. I trust that we have learned one or two things, and this will improve the management of our patients in our facilities. Let's have a high index of suspicion, and better we overtreat than undertreat. And if we are not sure, better we just state that we haven't assessed rather than saying a woman is negative and yet things are not okay. And for HIV positive mothers, let us give them shorter appointments, as we know that the progression is faster in our HIV positive women. Thank you to you all and have a pleasant weekend.